Hello, welcome back. The topic of this video is brachytherapy for prostate cancer using an LDR implant, low dose rate brachytherapy implant with seeds. So this is, you'll know from your clinical background, some autopsy series suggest that 30% of 30-year-old men have prostate cancer in some form. It's very common, and when it gets to the stage where it needs to be treated, brachytherapy is one of the options for the early stage disease. So the prostate, pretty small organ, about so big, right? Sits right behind the rectum, and because anatomically it's accessible, and so it's a great target site for putting seeds in because you can visualize where they go. And we'll go through how that works. All right, here we go. So I'm going to start with an overview. So anatomically, we have the prostate gland sitting anterior to the rectum. Superior to that is the bladder, and the bladder drains out through the urethra, which runs through the middle of the prostate gland and out. So in this procedure, it's possible to visualize the prostate with an ultrasound probe. In the rectum, the patient's leg is up and out of the way. So if you want to review ultrasound, you might want to go back and do that. That's in video 23. It describes how ultrasound works. So this method is called TRUS, transrectal ultrasound for visualization. All right, now eventually seeds are going to be put in through needles that are guided by this ultrasound probe. And I'm going to describe how that works in detail in a minute. But let's first look at how you prepare for a case and how you get the images in to plan for a prostate implant. So with the ultrasound probe, you can grab an axial image. Here I'm showing this as a green slice here. And then you move the probe and you grab another image. Move the probe again, grab another image. And then in this way you can build up images through the prostate. So here's what those look like. You'll see a slice of the prostate. The TRUS probe is at the bottom. Move on to the next slice by retracting the probe, next slice, and so on. So you move through the prostate, slice by slice, moving the probe. You're going from the base, which is the bladder, to the apex, which is at the bottom. So here are all the images together, and you visualize the whole prostate. Now from these images, a treatment plan can be made, which tells you where each seed should be placed. So I'm going to come back to that treatment plan in a minute, but first let me describe how the rest of the procedure will be done once the plan is ready. So once the plan is done and seeds are ordered and everything's ready, the patient comes back in. We go into the same position, again with the ultrasound probe. Now there's a template affixed to the probe. This template is a square grid pattern with holes, and each hole is labeled, and that goes according to a label on the treatment plan. So you can put a needle into that hole, and that will go to a specified location in the prostate. So here's what this might look like then. A needle comes into a particular hole, you go in, you figure out where the end of the needle is by imaging with the probe. And so you can verify the position of the needle in the image, and you can pull the probe back and forth so you get the tip where you need, and then the seeds go in. Next needle goes in, verify the position, drop the seeds, and so on. Here's the stepper. This is what moves the probe in and out by a precise amount, so you know where you are from in the base to apex dimension. Okay, so you finish up the implant, putting in seeds. I'm showing just in one dimension, but of course this is a three-dimensional problem. Seeds can be either loose, one by one, or stranded together, or loaded in a needle. I'll show you that in a minute. But in the end, you get the prostate with the seeds in it. Now let's move on and talk a little bit about treatment plans and how seeds are put in and so on. Here I'm showing one image from the pre-implant TRUS study. And you'll see the prostate outlined in green, and then the isodoses in different colors. The seeds in this particular slice are shown in green. And then you'll see some other holes that are hollow. That's where needles are going. And those are going to go in and drop a seed at different slices, either superior or inferior to this particular slice. So you'll see there's quite a few seeds, and if they're put in the right place, you get an isodose that covers around the prostate. A couple of things you're looking for here. You don't want hot spots in the urethra, which goes through the middle of the gland. You try to keep that a little cooler. You don't want hot spots near the rectum or seeds in the posterior part, because, again, that can lead to complications. Here is what the needles then look like for this particular plan. So each line here is one needle, and they all go into a different hole as labeled into the template. And if you deliver them in this pattern, then the implant would have a good coverage according to this plan. There are different ways to obtain seeds and needles for a prostate seed implant. Here, I'm showing preloaded needles. The manufacturer loads these needles with a seed, a spacer, in the right order. They're not connected together, but they're inside the needle, and the needle is sterile. And you insert the needle and pull the sheath out, and the seeds drop. These can also be stranded together so that there's a sort of a suture material around it, so the seeds are held together in a line like a little train. Also, it's possible to do implants sort of free-handed. So there's an applicator where you can drop the seeds one by one along the line and visualize with ultrasound as you do that. It requires a lot of skill, but there's a lot of flexibility in doing that as well. Let's talk now about some of the isotopes that are used and what typical prescriptions are. There are a couple different options for isotopes. A very common one is iodine-125. A prescription for that for monotherapy, so prostate seed implant alone, would be 145 gray typically. Another isotope in fairly common use is palladium-103. It has a shorter half-life than I-125, and the energy of the photons coming out is slightly lower. So, as you might expect, the dose is different. The dose here is lower typically. So sometimes implants are performed in conjunction with external beam radiotherapy. For example, you might give 45 gray external beam plus an implant. In this case, the dose of the implant is lower, 110 for iodine typically, and typically 100 gray for palladium. Now, there are other isotopes as well that are less commonly used for prostate seed implant, but you should know about them. There is cesium-131, very short half-life, 9 days. And there is gold-198. These are less common, but have appeared. Now, I want to make a couple comments about quality assurance and safety around implants. Some important references here are AAPM Task Group 64 on prostate seed implants, AAPM Task Group 128 on the QA of ultrasound systems, and then AAPM Task Group 56, which is about brachytherapy generally. There are also guidelines on prostate brachytherapy from the American College of Radiology and the American Brachytherapy Society. So, number one, there needs to be a post-implant study of the dosimetry of the implant to understand the quality of the implant and whether it was good. And this is mandatory. Most practices do this 30 days after the implant. It can't be done with radiographs. Those are good for counting the number of seeds, but you have a difficult time visualizing them with respect to the prostate gland. Rather, CT is used in almost all cases. It is possible to use MRI, but the seeds are hard to visualize there, and so those typically would be done with fusion. So CT is the primary modality for this to get a post-implant study. So second important QA task is you need to verify the activity of these seeds that have been ordered. The manufacturer sends them with some activity specified, and the physicist needs to check that that is the actual activity. The rule is you should assay at least 10% of the seeds that are used in the implant, and those should be within 3% of the specification from the manufacturer. So this is done in a well chamber. So you put the seed in, typically in the well chamber, measure a current, and then from a calibration factor, where you know the number of millicuries per unit nanoamp, let's say, you can determine the activity of the seed. So here's an example assay. And you have to make sure the dates are right, of course. If the manufacturer assays on one day, and then you assay the seed 3 days later, it will have decayed, right? So you have to correct for that. Also, you want to verify the loading of the seeds in these needles if they're preloaded. So here is an autoradiograph where the the needle is lays against a film, and you get an exposure on the film, and then you can check the spacing between the seeds to make sure that it is correct. The final thing is about surveying. So you survey to make sure that there are no seeds left behind, that everything goes in the patient. So typically you would survey the room with a survey meter before the patient comes in, make sure there's nothing to start. Survey the waste that comes out during the procedure, and then at the end, survey the patient to make sure that they meet the release criteria. And you can see the video about protection, about what the numbers are for release criteria and instructions to the patient after an implant. All right, so there you have it, some of the basics of prostate brachytherapy. Now, you can actually do prostate brachytherapy with HDR sources, high dose rate, although it's less common than the low dose treatments. You have to do multiple fractions of a treatment in the hospital. It's somewhat more complicated, but so LDR has become kind of the major modality. Here is a list of further readings on this topic. There's quite a few of them, very good resources, really readable reports produced over the years, especially the AAPM reports are quite good, valuable. And then in the next video, we're going to stick with brachytherapy, but we're going to move on into the world of HDR, high dose rate brachytherapy. Okay, see you in the next video.